Dr. Rasouli, thank you so much for joining us today.
Hey, Chrissy, thank you so much. Let me, um, there we go. I'm so used to Microsoft Teams now, I'm sorry.
Yeah, I know everybody's so used to Microsoft Teams.
Uh, Here we go.
Perfect. We can see it.
Okay. Does that look normal to you guys?
Yes.
Okay, perfect. All right. So, good morning, everyone. I'm Jonathan Rasouli. I'm a neurosurgeon here at Northwell Health. I'm predominantly in Staten Island, and I predominantly specialize in spinal surgery. And I do everything when it comes to spine. I operate everything from the base of your neck, the neck, all the way down to the tailbone. It sounds a little weird because people often think spine and they think of ortho and they think brain stuff is with a neurosurgeon. But as neurosurgeons, we do everything that's related to the central nervous system. So that's brain, spine, nerves, everything. So when I was starting off, I was very interested in the brain, but eventually my interests kind of migrated over towards spine. As you will see, I'm going to show you some cool cases that we've done, and you'll see why I really, really like the spine. So a little bit about neurosurgery before I jump into it. I got interested in neurosurgery very early in my medical school career. It was probably right around my second year. And so maybe some people might argue that's a little bit late, but uh, I liked the idea of working with my hands. I liked the idea of being in the OR, and I was really fascinated by the brain. I just thought it was so incredible. There was so little out there in terms of literature and so little that we knew. It was just so fascinating to me. So I was like, wow, it's pretty cool. I like the idea of working my hands. I like the idea of being in the OR, working with a surgical team, and I liked the brain. So it seemed kind of like a natural fit for me. Um, One of the things, again, as I mentioned before, is that people often think that we're just completely confined to the skull and the brain, and that's very much not the case. And you'll see it's such a diverse field with so many different subspecialties within neurosurgery. I mean, we're so highly specialized, but at the same time, neurosurgery is such a diverse field that you can have such drastically different careers within that kind of that broader context of neurosurgery. So it's one of the things I really loved about it. It's so and kind of when I think about what I really like about neurosurgery is that it's just really challenging. You see very complicated patients. Every day is a brand new day. I never get bored with my days. It's such a nice hybrid of medicine and technology. And as technology advances, I feel as though our field also advances in tandem with the technology. It's not like we're being replaced by as technology gets better. It's not like we're being replaced. It just makes our lives easier, which is great. Um, Everything we do is state of the art. It's super like high tech, almost like Star Wars, Star Trek stuff. And at the end of the day, you're really helping people. So it's a great, you're doing something really fascinating, really challenging, really complex, and you love it, and you're also helping people at the same time. So it seemed like a natural fit for me. I was really in love with it. Um, and as I mentioned before, you have many different subspecialties within neurosurgery. So, and this is just a small list. I mean, there are actually a couple more other than this on top of it. So, you can, usually the natural thing is to go into brain tumors. So we can do tumor resections, and there's like 500 different subtypes of different tumors all over the brain and spine. We have vascular neurosurgery, which is very, very in vogue right now with strokes and aneurysms and arterial and venous malformations of the brain and spine. Pediatric, you can just see this list, so many different things. This is super cool too. When I first started neurosurgery, I was more interested in functional. And then what that is specifically is when we take little electrodes and put it into different parts of our brain to achieve a certain outcome. And you can see with Elon Musk and Neuralink, they're looking at a way of putting essentially a computer chip in our brains that can help augment certain things like our memory, our cognition. It's like pretty sci-fi, pretty cool stuff, you know? So, and that's happening now, these are stuff that when I was in residency, I thought this was like, 30 years from now, but it's like happening now. It's pretty cool. It's a very exciting time. Spine, which I'm interested in, it's a very diverse field too, and we'll talk a little bit about that. And peripheral nerve as well. I don't want to forget about that. That's very cool, very interesting as well. Um, when I was in med school, this comic came out talking about kind of like the stereotypical different, the stereotypes of different specialties, and I thought they did one neurosurgery, which I thought was pretty funny and pretty realistic. We're like the workaholic egomaniacs that are trying to get like 10 cases done a day and, in love with ourselves, So it was funny. I thought it was pretty good. So just a little bit, I'm gonna talk a little bit more about this and we'll go right into some spine cases. Um, what is neurosurgery residency? I get so many people ask me about this, and it's funny. My parents, I feel like every single time I ask them, and or every time I explain it to them, they keep asking me over and over and over again. So, how long is it? What do you do? Like, what exactly do you do? And I've probably explained to them about 500 million times. They still don't quite understand what it is that I do. But so it's a 7-year program. It's 7 years. It's the longest residency of all the residencies. Um, most are somewhere between, say, 3 to 5 years. Neurosurgery is 7 years. And typical programs these days are somewhere between 1 and 3 residents, which is a very small class. As a comparison, a typical internal medicine class can be like 20 or 30 residents, or a typical orthopedic surgery residency class can be about maybe 5 to 10. Neurosurgery is like 1 to 3 maximum, and that's three a year is very rare. Um, in terms of the way the program itself is structured, it's a lot of variation between the programs, but this is kind of the general structure of most of them. This was my particular one at Mount Sinai where I did my residency. So the first 2 years, you're a junior resident. You're holding the pager, you're taking call, you're seeing patients on the floor, you're scrubbing into cases from day one. I mean, it's very, very busy stuff. As you progress through the years of neurosurgery, um, you start doing less of the floor work, and you're kind of more of this supervising, and you're kind of looking more at the broader picture, if that makes any sense. So typically, we have 1 year that's completely protected in terms of research. So you specialize in something that you're interested in. So by that time, I mean, you've been in residency for about 4 years, right? So you should have some sort of idea of what you want to do. So if you're interested in spine, you do a year of spine research. If you're interested in functional, you do a year of functional research. And then you kind of, as you finish up your residency years, you're more of a senior resident. And by the time you're a chief resident, which is your last year, you're pretty much almost an independent neurosurgeon at that point. You're doing cases independently. You're making management decisions, of course, under the supervision of an attending, but you're much more independent at this point. So you should, by the time you're done in your 8th year, if assuming you don't do another fellowship year, you're like ready to go. I mean, this is like, you've been waiting for this for almost 10 years at that point. So it's like, it's good. There's a reason why this residency takes a long time. And, the point of it is to make sure that you're very well trained by the time you come out. So some of the things that we see, for example, different types of tumors, right? So you can see this is an example of an MRI. We're looking at a cross section called a sagittal view. So you're looking at kind of like this, right? So the nose is over here somewhere. This is the base of the skull, and this is the brain, right? And you can see right here, this is a type of tumor called a meningioma, which grows from the meninges, which is a membrane that lines the brain, okay? So I'm not actually able to see the chat here, but I'm gonna ask you guys a question. Maybe Christy, you can help me. I can't see the chat. So if
Yeah.
people answer. Okay, so what would you say is a more difficult tumor to treat? Would it be this one, or would it be this one? One or two? What's more difficult?
Let's see. Somebody said two, two, second one, second.
Everyone's saying two, right? Okay, good.
Yeah.
Good. All right, good. Right? I mean, you guys, I don't know. I assume there are not too many neurosurgeons in this group, but you can see, you don't even need to be a neurosurgeon to see that this tumor is much more difficult to resect than this one. I mean, hey, they're both difficult, but this one is way more difficult. Why? Because you can see, look, it's much deeper in the brain, right? It's much, much deeper. It's almost in the center of the brain, right? And look at all the normal brain that surrounds it. How do you get access to this tumor, right? It's very difficult. Now, for bonus points, does anyone want to guess what kind of tumor this is? What gland is this growing from? Starts with a P.
pituitary gland, pineal gland. I have a mixture of pituitary and pineal.
Okay, good. So it's pineal. So this is from the pineal gland, right? The pituitary is actually right here where my pointer is. Draw it. So it's right here. Pituitary gland is right here, and the pineal gland is right here. So this is actually a pineal gland tumor. So it's very difficult to resect this. This is one of the toughest of the toughest kind of cases we can do. So but it's cool stuff. Like this is like a Monday in neurosurgery, you know? So it's very interesting how it's such a dichotomy between the stuff we do in the OR and the case that we see. And like this for this patient, this is the scariest moment of their lives, if you think about it, right? Like, can you imagine how scary it would be if you had this kind of a tumor and you were told this is one of the most difficult tumors to resect, right? I mean, it's terrifying, right? But for a neurosurgeon who specializes in this is a Monday. This is literally a Monday. So it was unbelievable to me. Now, getting to more spine cases, right? So this is a patient who had very severe osteoporosis and walked into our emergency room. I couldn't believe it when I saw this MRI. So you can see that it's complete, the bone that should be here is completely collapsed. It's retropulsing back into the spinal canal, and there's pressure on the spinal cord and the nerve roots in this area. So this patient needed surgery. We often see a lot of trauma cases as well too. If you look on the left side here, right, this is a CAT scan of the patient's skull. I want to point out some stuff. This is the nose, right? This is the nose. And what's this thing right here? Does anyone want to take a guess? What is this?
Someone said I. Anybody else got some guesses?
Well, yes, it is the eye, right? So, okay, what's the difference between this and this right here? Any guesses? I can't see, unfortunately.
Yeah, let's see. Everyone's kind of quiet. Somebody take a shot.
Yeah,
Oh,
so I'll take a shot. It's okay.
some
I will
air.
hold it against you.
Somebody said some air.
All right, so what is this? Okay, what this is a taser dart, believe it or not. See how shiny this is? This is metal in a CAT scan. It looks like this. So this is a guy who attacked a police officer, and the police officer took out a taser gun and shot it to kind of immobilize him. And one of those darts unfortunately went into this patient's eye. So this is what this looked like. This was kind of an unbelievable case. And over here you can't see this was a gunshot wound to the spine. You can see how it went straight. The bullet went like this. See that? You can see how it just kind of pulverized that bone. Now, unfortunately, with gunshot wounds, right? With gunshot wounds, they're the most difficult to treat because even though it's not even the piercing that's the bad thing. It's really the blast. It creates almost a blast injury inside your body, and that's what's really kind of is so devastating about them, more so than the actual bullet itself. All right, this is an example of an intracerebral hemorrhage. This is a patient who had a stroke that bled into the brain, and you can see it's right in the center of the brain. And when this happens, the patients can get something called hydrocephalus, and that's when your brain makes fluid. It's called cerebrospinal fluid, and this has to circulate and escape from the center of the brain, go all around the brain, and go into the spine. Now, if it gets trapped because of blood, it builds up, and it just keeps building and building and building and building, and it's called hydrocephalus, and that can be deadly. That can kill a patient in a matter of minutes to hours if it's not treated. So the way we treat that is we take we make a small hole in the skull and we put a small tube into the center of the brain where the fluid is and drain all that blood and that fluid away. So the way we do that is at the bedside. That's me. I was an intern when this was taken back in 2012. Um, this is what we do this as a bedside procedure, make a small burr hole in the skull, and we insert a little tube into the brain. You can see here, it's not that easy to see, but this is the tube. It's like this, comes like this. And what that is, this is another view of it here. That just kind of that tube is called the extraventricular drain, draining the fluid away. So it's a demanding, rewarding field, as I mentioned. It can be very difficult at times. This is a picture of me and my co-residents when I was an intern. This is back in 2012. It's been many, many years since then, but we're still going on. Anyway, all right. So enough of that. Any questions for me about neurosurgery as a field as a whole before I start jumping into the cool stuff?
Somebody did ask, would this be obstructive hydro since it's not being reabsorbed, and why isn't it being reabsorbed?
Excellent question. Yes, that is. So there are many different types of hydrocephalus, but if you want to think of if you want to broadly categorize them into two, there's obstructive and then there's non-obstructive or communicating hydrocephalus. When there's blood in the brain that basically you can think of it as plumbing almost. If it plugs up the pipes, right, very quickly, the brain does not have enough time to respond to that, and everything gets backed up. But if this happens very slowly over time in a more chronic manner, the brain will accommodate for that inability to absorb the fluid. And that is called communicating hydrocephalus. And that's a very, very different EDL. It's very different problem. It's treated differently as well too. And that's a good question. It is an example of obstructive hydrocephalus. All right, so spine. One of the reasons I liked spine was not just because of some of the cases I'm showing here and the things I liked about neurosurgery, but what I really thought was cool about spine was it took all the principles of cranial or brain surgery and made them much more broad. So what I mean by that is we can have, our cases range from the most smallest, intricate microscope, working around the spinal cord. If your hand slips like this, you can potentially paralyze a patient. It's like super, super intricate and skilled to the biggest cases where, you have a chisel and a hammer and you're like fracturing the spine, you're putting in screws and rods and, you're like bending the spine. I could all be in one case actually in the same day. So I thought that was just super cool. I like you kind of get both of the experiences in a way. So I want to show you 3 examples of different patients, and 3 of these were treated very differently, as you can imagine. So you can see here on the left panel, this is a guy these are all my patients. This is a patient who presented with he basically was completely hunched forward. He couldn't even look up. And what happened is that he had multiple spinal surgeries that went bad. And you can see that he was fused from his first vertebra in his neck, C1, all the way down to the last vertebra of his thoracic spine, T12, C1 to T12, right? And then they basically didn't do too much in his lumbar spine. What happened is he fractured some of his screws at the bottom, and he was completely pitched forward like this. So this guy was in tremendous amount of pain when he came in, right? So you can imagine, how do we fix that, right? Okay, that's one example. Then in the middle is an example of a elderly patient who had osteoporosis and developed a pretty significant scoliosis, as you can see. So the spine curves like this, right? So their scoliosis is basically an abnormal curvature of the spine, right? And this can happen at birth, or not, well, not at birth, but when we're much younger, and that's called idiopathic adolescent scoliosis, right? That's the most common form that is typically caught when you're young, during puberty. If you remember in middle school, when we had those tests where we would lean forward and they would check our backs to see if we had an early scoliosis. That's basically what that is. Or this can happen later on in life when we're adults. Unfortunately, as we age, we naturally lose calcium in our bones. They become softer. We lose muscle mass, and the ability for us to accommodate for changes in that become less and less as we get older. We can develop a scoliosis. It's very similar in a way. And this is what's called an adult spinal deformity. So it's a little bit different. It's treated differently. And then on the right side, this is a patient who had a spinal fusion and they were fused. Now you can imagine in the lumbar spine, lumbar is, the way I remember it, lumbar is lordosis, meaning there has to be a curvature. There's a natural curvature to your lumbar spine that's lordotic. And if you don't have that, right, and as you can see, this patient's spine is very flat. It's almost like a board. It's like a plank of wood. If that's the case, then it's very painful over time. It's not natural for our bodies to be in that position, and it's very hard to overcome that. For some period of time, patients can overcome it by tilting their pelvis in a certain way and kind of walking in a certain way. but eventually it just becomes too painful. You just can't do it. It all falls apart. They become almost hunched forward like that guy on the left. So how do we treat it? So what we did, I'll show you. So these are kind of the post-op scans for this patient. This guy, we had to extend them all the way down to his pelvis. So we extended his contracts all the way down. You can see he's much more full. He's much more standing upright as compared to where he was before. This patient, we did a very similar thing. We did osteotomies, which are little controlled fractures in the spine to bring her back, to pull her spine back to a normal alignment. And we locked it into place with screws and rods, and you can see some of the hardware that we put in. And in this patient, we did something called the pedicle subtraction osteotomy to restore that natural curvature of the spine. Whereas before it was flat, you can see now it's much more curved. And this is different ways that we treat a bunch of different pathologies of the spine. But you can see in a lot of them, right, or at least in 2 examples of the 3 I showed you, these patients had previous spinal surgery, right? So before they got to me. So this one had many, many surgeries. She also had many, many surgeries, right? So a lot of what I do is revision, meaning, you hear of people who've gotten spinal surgeries, and it can be in many ways a never-ending story. And that's unfortunate because unless it's done right, it will become a never-ending story. Your body will accommodate in certain ways that are not beneficial to you until the surgery is done correctly. So it's very important that if let's just say a loved one is going to get spinal surgery, you get multiple different opinions. You really do your research and do your homework before you get surgery, because it can be very life-changing in certain ways, as you can see. Okay, so one of the things when I first started my residency in 2012, and I would do these spinal surgeries, we would do a lot of this with an X-ray, actually, and that's what's called freehand technique. And you can imagine you're wearing this big, heavy lead gown, and we're taking a bunch of X-rays during the case. And although the cases went fine and everything was fine, the patient did well. These were very challenging because the lead is heavy. You're getting all these X-rays. You're radiating the room. You're radiating the patient. It wasn't really ideal. And at the time, we were also using something called neuronavigation, which I'll show you a little bit more about. And that is basically using a computer to put screws into the spine. And now we're much more using robots to help us during the surgeries and help us place instrumentation in the spine. So what do I mean by that? So it's not really, when we think of robots, right? It's not like a plug and play thing. It's not like we plug in a robot, we push a button, okay, I want you to do this. And then we just leave it alone. The robot, puts in all the screws and we just don't do anything. It's not really like that. Basically what the robot does, and I'll show you in a picture, it helps us put in screws. It's almost like another arm, and you'll see that. It'll make more sense in just a little bit. The other way we think of a robot is something called the Da Vinci, which is more used in general surgery and other surgical fields. We haven't really adopted it too much in spinal surgery or in neurosurgery. And what that is literally like a surgeon sitting at almost like a computer desk and working, with a little thing, and the robot does all the surgery. We don't really have that yet in neurosurgery. And there are many different types of robots, but you'll see. So just to show you an example. Oh, sorry. Okay. How do I think I'm doing something wrong here. Take it off that eraser. All right. Well, I'm trying to show you this video. Hold on. Give me 1 second. I'm gonna stop sharing for 1 second. Oh, there we go. Okay, there you go. All right. Escape button. That's how you do it. Okay. So this is how we would do. Let me pause for 1 second. I'm just showing you an example. This is like in the OR. So this is my assistant here. This is my scrub tech. He's handing me instruments. and that's me over there. So I'm showing an example of how we would put in pedicle screws. Okay, you saw those screws and rods on that exercise I showed you. How do we put those in, right? Okay, so this is kind of the traditional way of doing it. All right, so this makes sense. So we literally have a mallet and a chisel, right? This creates a small osteotomy. We take a little piece of bone out. Okay, I'll fast forward this a little bit. Ah, all right. So as you can see, what basically what we're doing is um, we're just taking out bone and stuff, creating small fractures in the spine. And what that does, it loosens the spine, right? So you can imagine if you have a scoliosis, right? How do you like, as the spine is all curved like this, how do you pull it back to midline? So this is how we do it. We create small fractures in the spine, right? And we use instruments, literally tools. They almost look like tools that you would see at Home Depot. No joke. And what we do is we basically create a path for the screw. And once that's done, we use a couple of different instruments to actually place the screw itself. So you can see it's very like manual, physical process. And that's just for one screw. And unless you are, and if you're doing like a long segment fusion, if you're instrumenting multiple levels of the spine, sometimes 10 or more levels, you have to use it at every single level, right? It's very exhausting as a surgeon. And you're not even really done with the case. You're just putting screws in. You have much, much more work to do. So now, let me just go to the next one. All right. So now we have a robot. This came out about 10 years ago, a little bit more than 10 years ago. So you can see it's much more elegant, right? You have a robotic arm. Look at the computer to the left over here, right? And if you pay attention, see, it shows you exactly where you are, right? It shows you like the predicted path of that screw, where your instrument, that blue is that drill, right? You're using power instruments, you're not using manual instruments. It just guides you exactly to where you want to go. You can see how you created that path with the drill, right? It showed you where that drill tip was. And there you see the screw, right? Look again at the computer. You're just looking at a computer screen, right? Look at that. See the screw going right in, right? You know exactly where that screw is in space. Pretty cool, right? Much more elegant, much more easier ergonomically on the surgeon. Um, in some ways, just easier and faster to do it this way than doing it manually. Um, so it's nice. So you can see what one of the things I really liked about robotic surgery and why I got interested in this was it's very I kind of like geek out on this stuff. I like the tech and I like the software and stuff. And this is what it was all about. It was, yeah, using computers, you're using software to put in your screws. It was a much better way of doing it, and I liked it a lot. And you can see how um, during the case itself, like this is just an example of how you can plan this out. You see the screws going in. You can plan this all before the surgery itself, so you know where these screws are going to go into the bone before you even go to the OR. And this, usually we just do this on the fly, in the case itself and just figure it out. You get a little bit better idea of what things are going to look like before you actually do it. So it's nice, and it really shines in the minimally invasive spine world, right? There's surgeries I showed you before where the exact opposite of minimally invasive. Those are like maximally invasive, big incisions, big surgeries, take a lot of time, a lot of recovery, but we're moving more and more towards doing the same surgeries in a much smaller way, which is easier on the patient. And another thing is that it really makes up for some of the intraoperative stuff that we have to deal with. Like, for example, just getting an X-ray can be a real pain sometimes. Like on the left-hand side, you see this AP and lateral image. These are very like almost a perfect scenario. And then here, if you have a patient who's, kind of overweight or the X-ray machine's an old one, it can be very difficult to see what you're doing. It's all washed out and it's hard to get a good image. So if you imagine you're putting in like screws, like how do you even see what you're doing here? It's very tough. So what's nice about using the robot and using some of the more advanced technologies that we have these days is that it gets rid of all this guesswork and it makes things much, much more, it gives us more confidence when we're doing the cases, especially if sometimes when unfortunately you're dealing with a big patient who may have wound issues as well, MIS can be preferred. So this is just an example of a patient who had a unique tattoo, and we wanted to obviously instead of making a midline incision and kind of ruin this tattoo, she was very adamant that we preserve this. So we kind of worked around this, and you can see I think at the end we got a kind of a nice cosmetic result around this tattoo. Before we'd have just go right through the middle of it and try to reapproximate it. It would never really come out quite right. So this was we were able to kind of work around it. Not saying that this is the main factor of our decision of whether or not we're gonna do MIS versus open surgery, but if we have that option, it's nice. It's also made us do complex spine a little bit in a little bit better way, a little bit easier for the patient. This is a patient who without getting into the nitty-gritty details, this is a patient who need a very complex revision, an extension of their fusion down to the pelvis. As you can see, this guy had multiple surgeries. He was developing kyphosis above the previous construct, and he was fused kind of in a bad way. Um, you can see that his back, right? His back is very pulled back relative to where his pelvis is. See that? So it's very painful. Just imagine walking like that all day, like this, right? So this patient's in a lot of pain. So what we're able to do using the robot in a much more minimally invasive, this would be like a huge incision, multiple, maybe even staged over a couple of days kind of surgery, take out all the heart rate. It's a very, very difficult case. Here we were able to kind of work around what he previously had and extend his construct proximally as well as distally down to the pelvis. So we got a nice result here on him. Very similar case as well too. We use a robot to do a technique called the kickstand rod. This is for a patient who had, as you can see, a very significant coronal deformity, had a previous fusion. And you can see that he was also fused flat, right? Look, there's no curvature here, but the curvature they have is like this, right? Now you're fused, so you can't change that. It's not like you can bend your back in a way to get out of this, right? So it's very, very challenging, very difficult. What you need in that kind of case is, unfortunately, more surgery. So the way we did this was we used a robot to put in more instrumentation, and we did what's called a kickstand rod. That's this thing right here. It's an additional rod in conjunction to the two rods in the middle to achieve a better coronal correction. So that was nice use of the robot there. And for patients who are very challenging intraoperatively, this patient had very severe osteoporosis and a very significant curve and had all kinds of issues. We were able to use robot to do a smaller incision and achieve a nice result. Now, ultimately, this patient had a unique way of showing off their back incision. Excuse me, they got a tattoo, but they did it quite well. Now, in the realm of pediatric scoliosis, as I mentioned before, these curves can be very, very significant. So you can see here, this patient has a very, very significant or double major curves. You can see in the lumbar and thoracic spine. And if you look at a picture of them from the back, you can see this big bump here. This big bump, right? See this? Significant asymmetry. And not only does it cause pain, but also the patients they don't like the cosmetic appearance of this. They don't like, they don't want to go to the beach. They don't want to take their shirts off. It creates a lot of issues. So it's not just the pain aspects of it, but also the psychosocial issues of it that it creates a lot of stress and anxiety, and those have to be dealt with as well too. So it's very these surgeries for these patients, these tend to be the happiest patients for me. So what we did here is we planned out again a fusion surgery, right? But the question is like for me, right, when I see this X-ray and I say, okay, we're going to do surgery on this patient, right? I wonder, like, what is it going to look like at the end? This ultimately we got a great correction here, right? But like, how do you know that it's going to turn out this way, right? How did we know that doing this many levels was going to be the trick, right? Because why don't we just go from like all the way up here to all the way down here? How do you know? So what's nice about again with the robot is that you can actually the software has gotten so good that you can actually predict what it's going to look like. So so you can see, okay, so here we were planning out. This is the preoperative X-ray, right? And what the software is able to do is actually predict what it's going to look like. So you can see it was showing us that instrumenting from here, from T4 to T10, you can see this is what it was going to predict, right? So this is what was showing us where we started, right? And this is where we're going to end if we do this, right? And all things considered, not bad, right? I mean, that came out pretty accurate. So it's nice from that perspective. You can actually, you can almost like have a little bit of um, a futuristic view of what this is going to look like. Now, this is, there are obviously some limitations to this. I'm showing you the best example of this, right? But it's pretty good. It's pretty good. I have to say it's about 80% on the dot, which is nice. It's nice, if anything, you can always change things during the surgery itself to achieve that desired correction, but this is good. Um, so, there are many benefits to minimally invasive surgery, as I showed you before. It's just easier on the patient, but it does come with some expenses too. It's not nothing's perfect, right? There are a lot of cons to this too. I would say that in my practice, I kind of the pendulum swings a bit. When I first started, I was primarily minimally invasive, and everything was MIS robotic, and then I swung to the opposite, and I started doing everything maximally invasive, big incisions, and now I'd say I'm kind of going more to the middle, um, with minimally versus like I hate to use maxillary, but to say open. So minimally invasive versus open surgery. I mean, it's kind of case by case, selected basis. Um, but generally, my bias is open. I tend to do it bigger incisions and kind of a larger surgery. So, we can use it for a whole bunch of different things, not just putting in screws, but we can also use it to decompress the spine, to take out disc herniations. This is just showing some examples of how, the rods that you saw, right? The screws have to line up nicely with the screw heads. And if you don't, they can really it can be very hard to put that rod in at the end. So it's nice. You can actually plan this in a way that you get the desired correction and what we call the screw cadence. So it's just an example again showing you this large surgery that we did with this fairly small incisions that were cosmetically appealing for this guy. And you can see the difference between what we would have done, this large incision in the middle versus these two small incisions on the back. I don't know. Some people might argue that this is maybe more cosmetically appealing. I think this looks better to me than this one, but we try to strive for the best decision possible. Smallest decision to get the maximum result. Let's put it that way. Um, these are some things that we do. We use a robot to do decortication, to achieve fusions in a minimally invasive way, which is nice. To put in screws to help us with placing what are called cages or inner bodies to help us do these things. And just to show you some more examples, I'm going to skip through this. Now, it's not perfect. There are a lot of downsides to this. One of the main ones is time. It's not necessarily putting the screw. That's actually the easiest part. It's just the setup takes a lot of time. You have all these trays and all this specialized equipment, and the staff needs to be very comfortable using it. And unfortunately, we don't exist in a world where we have a hospital that just does spine, right? That's rare. I mean, they do exist, but it's rare. It's so the staff is often new and they may not know how to use this equipment. So it's like, and if you're not doing this all the time, um, whenever you do use it, it becomes kind of a whole thing and it can add a lot of time to your case. And that's not great. That's not a good thing. It's costly and to buy the tech and to buy the equipment, all that stuff costs a lot of money. So it has to be made up somehow with the cases that we do. And, uh, there's no real strong evidence to show that this is any better than X-ray and freehand technique that I showed you. So the jury is still out on this. Until that evidence really comes out, this is not really standard of care. So, we're using a lot more technology. This is a paper you guys can look at. I wrote this when I was in my fellowship, looking at artificial intelligence robotics. There, what we did here, just to quickly touch base on it, what we did here is we looked at all the papers. This is back in 2020. Unfortunately, it needs to be updated now. But we looked at all the papers. We did a retrospective study, look at all the papers that have been published on robotic spine surgery. So this was over 1,000 patients, right? There were some conflicts of interest studies in there. Unfortunately, it just can't be removed from it. And there is some evidence of therapeutic illusion when it comes to this. But the accuracy of this was somewhere between the order of 95 and 98%, which is outstanding, which is outstanding. So if you believe the literature that's published right now, it's great. It's really, really great. Um, is it, but it's not, I want to stress, it's not any better really than doing it the standard kind of old school way. Um, so if there's no, there's no difference really. So if you have a surgeon who is robotic versus a surgeon who doesn't use a robot, there's really no difference, right? Um, this is an example of not a robotic case, but a computer navigated case that we did at Staten Island when I first got here. What this is basically this is a patient who has severe spinal stenosis. They had a previous construct. They were fused from L4 to S1 in their lumbar spine, as you can see on the next slide. Right, they had these screws and rods that were put in, and they developed very, very severe, what's called the J segment degeneration, one level above this. So what we decided to do was come from the side or do a lateral lumbar fusion, where we basically take this whole bad disc out and we put a new implant in there that restores the height, it restores the alignment in a way that's very minimally invasive and easy on the patient in terms of recovery. So the way we did that, excuse me, this is showing kind of intraoperatively, we placed a stereotactic array, is a little pin that goes in the hip, and that's what the robot or the computer kind of sees and develops a 3D image of the patient based on that. So we do that, we plan out our incision, coming from the side, just showing you some images. We have this little pointer, it shows us where our trajectory is going to be, where we're going to put the inner body in. It's got, the disc. That's kind of our trajectory. So you can see that this is more of a lateral trajectory. It's going through a muscle called the psoas, right? But our trajectory should be more anterior to this. Some of the great vessels here, they kind of highlighted for you so you can see we try to avoid those. And then this is just placing in some of the implants and some of the inner bodies, showing you. So you can see, whereas we went from completely collapsed, this nice big cage that we put in there to restore the height, restore the alignment, and give them what's called indirect decompression. So it was nice. And this patient went home the same day. They didn't even stay in the hospital. So what we normally would do, we come from the back, go through the scar tissue, take down all the adhesions. There's all these risks attached to that, and the patient would stay in the hospital for a couple of days. Here, we got a great result, and the patient went home the same day, which was great. So this is good for the patient's recovery, good for the patient healing, good for the hospital standpoint in terms of resource utilization, and so everyone's kind of a winner here in this kind of a case. So we're trying to do more of these kind of minimally invasive, easier for the patient kind of surgeries as compared to kind of the more of the old school stuff that we had before. Just showing you side by side what we had before, and we're doing like stretching the spine in a way, which is good. Okay, any questions?
Yeah, let me check the chat really quick. Somebody asked, what is the recovery process like for open surgery in comparison to robotic surgery?
That is an excellent question. So, recovery process of open versus minimally invasive. So I have to say, it really depends on the surgery that's being done. Okay. If we're talking about a small surgery, such as taking a microdiscectomy, or a patient who has a herniated disc in their lumbar spine, right? So you can do it either open or minimally invasive. There really is no difference. The patient will go home the same day, and the recovery time is the same, regardless of just the incision size is a little bit different. Now, if we're talking about some of the cases I showed earlier, let me pull that up quickly. So if you're talking about a case like, let's see, let's go back. All right, we're talking about a case like this, right? Minimally invasive versus open. If you can achieve a good result utilizing a minimally invasive way, let's say all things considered, if they're equivalent, right? The recovery time is pretty significantly less with minimally invasive versus open. You're talking about multiple days difference in the hospital. As you look over time, right? If you expand that over time, let's say over a year, the recovery time is really no different. But in terms of hospital length of stay and pain control, it's very much different. These patients are in far less pain. They're able to participate with physical therapy much sooner. They're able to, they're mobilized more quickly, and that's good for the patient because that reduces the incidence of things such as, DVT or deep venous thrombosis, urinary tract infections, pneumonias, wound infections. wound healing problems. The faster you get the patient up and walking, all these things get better. So it's good for the patient if we can do that. Um, Now, if you look at it over time, if you look over, 1, 2, 3, 4, 5, 6 months, those differences kind of go away and it becomes pretty much equivalent. So what does become more of a difference is the ability to achieve a solid fusion. Okay. And that's what the goal is in all these surgeries, right? Because you can just put these screws in, but they have to take, the body has to accept them and form bone around them. That's what's called the fusion. If you do not achieve a solid fusion, then this stuff will fail. It's just a matter of time. It'll take about a year, but it will all just break down, becomes loose. The scar tissue will form. You're not going to get solid bone. And that incidence is higher with minimally invasive surgery. So that's the problem. You're trading one set of, it's like you're saying one set of pros and cons for another set of pros and cons. It's much harder to achieve a solid fusion with minimally invasive surgery than it is with open surgery. So, and there are more revisions. A lot of these cases I showed you before, like how they had previous surgeries, these were all done minimally invasive, by the way. So kind of a joke is that minimally invasive surgery, maximally invasive revision, So it's like a lot of these surgeries need to be revised. So it's not that great. It's not without its problems. So um, I would say that minimally invasive surgery is a good option for the right patient, but it's not always the best option for all patients, if that makes sense.
Yeah. Um, there is another question. I think this was kind of more at the beginning of your talk. Somebody had asked, was that ventriculostomy attached to a VP shunt?
So that ventriculostomy was attached to a closed drainage system. What that is that is a tube that goes in the ventricular system, is draining fluid, and it takes that fluid and drains it into an external system. Almost, I hate to say it this way, it's like a bag, basically. It collects into a bag, and then you can just change that bag out once it collects enough. Eventually, we try to wean them off of that external ventricular drain and try to take it out altogether. But if they are drain dependent, meaning the hydrocephalus is not resolving on its own, then you'll have to internalize that drain with a shunt. That patient ended up being okay. They did not need a shunt.
Perfect. There's another question asking about what the main challenges you face when implementing AI in the operating room, and how do you think AI has impacted surgical practice so far?
That's a great question. So, um, artificial intelligence and spine surgery, right? Okay. So, right now, as of today, let's say today is July 8th, 2025. Um, as of right now, as of today, we have not really done much with artificial intelligence yet. Okay. There are a lot of things in the pipeline, but it really has not made any significant impact in our practice yet. Okay. So where is it really going to make an impact? And really where that's going to be is going to be in two different ways. One is going to be in the clinical, in the kind of outpatient setting, where we will, when we see a patient in clinic, we talk to them, we get the history, we do a physical, we look at the imaging, right? Right now, you have to kind of, as a surgeon with experience and training, you kind of put all those things together and you say to yourself, okay, um, we are we are going to, based on this stuff, I want to do a, you know, L4 to S1 lumbar fusion on you because this is what I feel is best. But that patient can go to a different surgeon and they can get a completely different treatment algorithm or suggestion based on from that surgeon's own experience and training and stuff. So there's a lot of heterogeneity. So what's nice about AI is that it could potentially, not yet, but can potentially get all that information and come up with a suggestion on what would be the best thing to do. And not only would it be kind of generally the best thing to do, but would look at the surgeons, kind of the best surgeons, the surgeries that they do and their complication rates individually and say, okay, this might be the best thing for you to do. Because what I mean by that is, let's just say I'm the best person in the world to do a lumbar fusion, right? So, but I'm very bad at doing, I don't know, let's say I'm very bad at microdiscectomies, but I'm good at lumbar fusions, right? So the AI may say, hey, Dr. Zuli, um, you may want to consider doing a lumbar fusion on this patient because you're really good at doing it. And you may not want to do a microdiscectomy on this patient because you're not so good at doing it. But I think this patient needs a microdiscectomy. So you may want to refer this patient out to XYZ person who does really, really good microdiscectomies, right? So that's probably where that's going to head. It's going to give suggestions, it's going to help synthesize information, tell you like what may be a good idea to do based on all the available evidence that exists. The literature shows that, da 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 da, fusion rates are this, so that's where it's going to help in one. And the other one is going to be intraoperatively. So where that's going to help is going to be probably in the realm of putting in screws, doing hardware, or even just taking in data. We wear a headset or something, and there's like the camera, and its AI can look and filter and synthesize information, maybe give suggestions. The way I think about it is like if you've seen that movie Terminator, like when he looks and he sees that little thing, it's telling him all that like live feedback. It'll be something similar to that, but this is not here yet.
Yeah, that makes perfect sense. Another person had asked if you could explain to what degree of curve would people with scoliosis patients just be using a brace that would help fix the curve versus when surgery would be required.
So bracing is an effective option for patients who are not skeletally mature, meaning they're just still like in adolescence and puberty, they're still growing, right? And their curve is caught early. Okay. So it's like that's why we screen. Okay. So they're younger, it's an early scoliosis, and they have not essentially gone through puberty, it's still growing. Okay. And there's some you can still kind of push this a little bit further than just puberty. You can go a little bit longer than that. But usually not anyone over the age of 22, you don't really brace them anymore. The reason being for a couple of reasons. One, there's a high failure rate with the braces. They don't really work when they work, they work. But most of them don't really work very well. They're very uncomfortable. They're these huge things these patients have to wear. They have to wear it literally all day, every day. You can't take any breaks. You basically take it off to go to bed. Um, it's not really realistic to ask patients to do this. These are more used in like resource limited settings where they don't have either the equipment or the surgeon, the skilled surgeons who can treat this because um, really the best long-term results and the best short-term and long-term results are with surgery, like hands down. In very select patients, bracing is an option, but it's not really the go-to anymore for those reasons I mentioned.
Yeah, that makes perfect sense. I feel like that's like kind of a common I guess, kind of misconception that a lot
Yeah.
of people
I
have.
mean, if you're like, look, I do not want any surgery whatsoever. Put me in a brace and let's hope for the best. Sure. I mean, it's always an option. I mean, there's no downside. It's not going to make things worse, but it's not usually effective and it's usually just a waste of time. Very uncomfortable, you know.
Right, yeah. I guess since we're kind of on the scoliosis theme right now, another person kind of asked if scoliosis is corrected through multiple surgeries or once. So maybe you can kind of talk about when it's multiple surgeries are required.
Great question. So okay, so um, the answer is we really try to do it in one shot, if possible. The reason being is that it's just easier for the patient. It's easier from a resource setting, and it's sometimes just better in terms of just the planning kind of way things go in terms of their recovery, the rehab, the wound, the post-surgical drains, organizing stuff. It's easier just to get it done in one shot. But that's not always the best option for every patient. The reason I say that is if you have a very complicated scoliosis, such as this one in the middle, this was a very tough one, it's often better to stage this. The older a patient is, the more medical comorbidities they have, the more you should stage it. It's easy. That's going to be easier on the patient, safer for the patient, and just kind of better in terms of the way that surgery is going to go. So, for example, this one in the middle, we staged this over a couple of days during the same admission. Okay, so the patient came in on a Monday. I don't know if you can really tell, but we did something called the anterior lumbar antibody fusion. So we did ALIF. It's called the ALIF. So we put cages from the front at 2 levels, and I gave some lordosis. It corrected the curve. We let them recover for a day or two, and then we took them back to surgery and did the posterior screws and rods and some of the cement, as you can see here. So this was what we did to achieve this. We also did another cage in the middle here called a T-lift from the back. Um, so this was done over several days. This was a big surgery. This patient was in the hospital for a while. They were in the hospital for like about a month. They needed rehab, but they're doing well. They're doing great. This is actually one of my happiest patients. Um, a lot of this goes to show that a lot of this is just patient selection. That you can sometimes have even if they have a scoliosis like this, if the patient is unrealistic, there's certain patient factors that go into this, like what's their level of activity, and that's a whole different talk is patient selection. And now another example is patient on the right here with what's called flat back deformity. We did this in one day. So what we did a fairly large, we took the old hardware out. We did a fairly large osteotomy at the level of the apex of their deformity. And we re-instrumented them. So we were able to achieve a pretty nice correction there. So it really just depends on the patient. I wouldn't say it's a one size fits all, but in general, we try to do this all in one day if we can.
Yeah. So there's actually another question about kind of how you use neuronavigation for surgical planning, and kind of going back to the AI topic.
Mhm.
Um, and they also asked about 3D segmentation and if you've used any of this, if you could share your experience.
Yeah, I mean this is it. So what we do is we get a we can either get a CAT scan. It's usually done based on an MRI or a CAT scan. We either have this before surgery. It's a very special type of imaging study. We have to order this specially. It's called a stereotactic CT or stereotactic MRI. It's much finer cuts. So we either do that or we can get the imaging during the surgery itself. So we get an intraoperative X-ray or CAT scan to help us with the navigation. We get the images, it's uploaded to a computer, it segments it, and it gives us the AI will give us a plan, say, okay, hey, this is where I think the screw should go. Bop, bop, bop. This is an example of actually an AI generated plan. Now, that being said, right, this is just coming up with what it thinks is the best. It may not be what I would normally do. So uh, I may want to come more lateral on this screw, or I may want a more medial trajectory. The AI will not accommodate for that. It's just going to do what it wants to do, the way it was programmed to do. So uh, that's one thing. Now, when it comes to the navigation aspect of it, it doesn't matter whether it's a robot or we're doing it with the more traditional neuronavigation. It's basically the same. You're either looking at it. You're basically yeah. Here we go. This is a good example. So you're basically looking at this computer screen, right? As compared to looking down at the patient, you're looking at a computer screen to help put screws in. Yeah, there we go. So for example, like if you're just using navigation, not a computer, you have an instrument. You see this instrument that we're putting in? Do you see this little like X here with the little balls on it? That's that's how the that's how the computer tracks where you are. It's based on that. So um, with traditional navigation, you don't have this arm helping you. You're just kind of like you have all these degrees of freedom to put the screw in. Here, you're locked into a specific path. Some people like those degrees of freedom. They may prefer navigation over the robot. So there's no real like gold standard with this. I want to kind of stress that. Um, as compared to general surgery, for example, or urology, right? Almost like all the certain like cases are done with a robot, but very few people are doing it kind of old school way. It's not the same in spine surgery. It's not like everyone's using a robot or using navigation. It's not really standard of care, it hasn't really been shown to be significantly better than just using a traditional x-ray. It's an alternative. It's an acceptable alternative to.
Yeah, that makes sense. And this is also a really cool video that to show. So I'm glad that you added that
Yeah.
to your presentation. Another person asked a question about kind of the pathway of becoming a neurosurgeon. Obviously, becoming a neurosurgeon is a very long pathway. So they asked, what advice, mindset, or values did you carry with you to overcome obstacles that you faced in your journey?
That's a great question. That's actually a topic for a whole nother talk.
You're right, yeah.
If you want to have me back, I'll be happy to do it, you know. No, yeah, it's a topic for a whole other talk actually. But basically, to give you the Cliff Notes version of it, uh, I would say the key things are get started early. You know, if you get started early, it, see if you really like this, because there are a lot of, you know, with anything, there's no such thing as a perfect field, right? There are pros and cons to everything, right? If you feel that neurosurgery, if you're drawn towards neurosurgery, I would say get involved early. Like, find a neurosurgeon close to you, where you live, or where you go to school. Shadow with them. Um, Go see what like a day in the life is. See if you like it. Okay. If you feel like that's for you, then you should jump right into it. Get involved in research. Get involved in, go to conferences if you can. Stay involved with the local, when you're in med school, stay involved with the neurosurgery department that's in your med school, get to know people. It's all going to come naturally. But I'd say the key thing is just get involved early. The earlier you can get involved and stay involved, the easier it will be down the road when you apply. It just every year gets harder and harder and harder, and these applicants are getting more and more and more amazing, and it's very competitive. It's very competitive. So like every year is the hardest and most competitive year to get into. It's like every year is the most hardest and most difficult year to get into neurosurgery, and it just keeps getting harder every single year. So um, so I would just say just get involved early. Uh, uh, Find out if this is the field for you. Just go for it 100%.
Yeah, that's really great advice. And brain turns, y'all are kind of starting with that, with being a part
Yeah,
of.
exactly. Yeah, this is a great start. Like look at brain turns. Go see, uh, go to Lenox Hill if you can. Do some shadowing, some volunteering. Get involved in research. See if this is for you. And if it is, then you should go into it 100%.
Yeah. Well, I think that's kind of the end of our question and our time with Dr. Rasouli. So thank you so much again for joining us today and taking time to just talk to our brain turns. This was a very cool
Pleasure.
talk, and I've definitely learned a lot. And so at brain turns, if we could just say thank you, that would be awesome.
Thanks so much, guys. I'm gonna just show you one thing. If you guys want to get in contact with me, you want to shadow or get more involved, go back to the beginning. My Here's my some of my social media stuff. If you shoot me a text or shoot me an email or whatever, and just let me know, and I'd be happy to get you involved. It's always good to have more people interested in neurosurgery, and I feel like we're we're always looking for people to get interested in neurosurgery, so it's always good.
Yeah.
Thank you so much for having me.
Yeah, thank you so much.
Take care.
Thank you.